One of the unique things that we do here, people often say, well, why should you come to a cancer center? What's unique about what you do, or something that people couldn't get other places, is a treatment that we have for what we call peritoneal surface malignancies. They're basically GI cancers, most commonly colorectal, and actually appendix cancer, which is not that rare, that have perforated through the wall of the colon, the rectum, or the appendix, and they're spreading through the peritoneal cavity or the abdominal cavity like dandelions on your lawn. You get one, then you get two, then you get 50. This is that old thing where people talk about, oh, they opened up grandma, and 3 months later the cancer was all through her abdominal cavity. It wasn't because the air got in there. That's what about 20 to 30% of GI cancers do. When they break through the surface of the intestines and get access to your abdominal cavity, it actually acts like a petri dish, and those tumors can grow very, very quickly. Mesothelioma, primary peritoneal mesothelioma, is another one of the diseases that we treat. Historically, those have not responded very well to systemic or intravenous chemotherapy. It can work and it can have an effect, but it's very difficult to deliver high doses of the chemotherapy to the peritoneal cavity. So you pay a high price by giving a lot of it to the rest of your body with all the side effects for very limited spread or penetration into the fluid in your belly and those tissues. So unfortunately, the long-term survival for many patients with those diseases is fairly dismal. Thinking about it in a whole different way, why not give the chemotherapy right where it needs to go? What has developed over the last few decades, and we're one of the first centers in the US to do this back when there were probably 10, 15 centers, now there's probably upwards of 50 centers in the US, is to do what's called cytoreductive surgery and hyperthermic intraperitoneal chemoperfusion, or HIPEC. So it's easier to say little alphabet soup things than the whole title. And basically the concept is, and not every patient that has these diseases is a candidate. You have to really look at the individual. Are they healthy enough to tolerate what could be a fairly large operation? That's sort of the first hoop the person has to jump through. Is the disease confined to the peritoneal cavity? No spread through the bloodstream to other organs or spread into the spaces around the lungs, because we're going to kind of put blinders on and put very high dose heated chemotherapy right where it needs to go. And then the third one, which is probably the most important, is surgically, can we remove almost all or all of the tumor we can see with our naked eye? That's what we call the completeness of cytoreduction. If you can remove almost all the gross tumor, we know that there'll still be little microscopic cells there. So we then follow that up with a one-time intraoperative high-dose heated chemotherapy. It lasts about an hour and a half. We're heating it up to a bad fever. It's not boiling, but it's about 104 degrees. The heat alone can actually kill the tumor cells, where the normal cells are more resistant to the temporary effects of heating. And we're giving chemotherapy doses that are 2 or 3 times what you could get intravenously, with almost no absorption into the rest of the body. So we take advantage of that concept for some patients with kidney failure. Instead of getting hemodialysis, where they get their blood cleaned through a catheter on a machine, they put a catheter in their belly and they wash fluid in and out of their belly all day. The linings of the belly are designed that some things that get in there cannot get absorbed, and chemotherapies are one of them. So we can take advantage of the fact we're putting the chemo right where it needs to be. We're using surgery to set the stage for the chemotherapy to work. The less it has to kill, the better it works, and it's a one-time treatment. So the patient gets better from their surgery. It has not limited any of their other options in the future. They could always get IV chemotherapy later. Once they've recovered from their surgery, everything's done. And for many of these diseases, we would treat them once and then don't have to treat them again unless or until their cancer comes back. So in some people, it's cured them. They didn't need to get chemotherapy week after week or month after month, with a very low chance of being cured, coming in and getting blood drawn and all the side effects to the rest of the body. Even for the patients who aren't cured, these cancers typically destroy the intestines. They cause blockages and an inability to eat and malnutrition. By keeping the garden weeded, so to speak, keeping the dandelions from crowding out the tomato plants, keeping your intestines open, patients can still live longer. So again, what used to be considered a very dismal prognosis, we now have patients that are 5 years later and are cured, and their cancer has not come back, where they were previously told, within a year, you should start getting your affairs in order. So that's something that we started here in 2002. We now have 3 surgeons that do it, cancer surgeons, myself, Dr. Skitsky, Dr. Francis Scuti. We've published our data. Our outcomes are very good in terms of risks. We have 0% 30-day mortality. Complication rates are about 20%, 25%. 95% of patients are home within 14 days of their surgery. And our outcomes are also equivalent to what's published throughout the literature throughout the world in terms of colorectal cancer, mesothelioma, appendix cancer. So some people will try to put a square peg in a round hole and try it in anybody. that's really not how you'd want any of your care, not only your cancer care, but your car care, anything else. You really have to look at the individual and say, this isn't right for you. You're not denying them something that they should have had. You're telling them that it's more likely to hurt them than help them. But for the appropriate patient, this is something that has a 25-35% chance of curing them versus a 1-2% with intravenous chemo. So it's definitely something we want people to be aware of. We're happy to see people and make an assessment whether they're a candidate or not, and if they're an appropriate candidate, to provide them with this very unique focused regional therapy.